Good morning, everybody. I would like to welcome you for this session 72 on in vitro maturation, and thank you to be here this morning, early in the morning, the last day of ESHRE meeting. I hope you have enjoyed already the rest of the meeting. It's my honor. I am honored to share this session today. I am Isabelle Demeestere from Belgium, and I'm honored to share this session today with Dr. Ruso. And we are going to invite the first speaker.
Thank you very much, Professor. Good morning, everyone. It's a great honor to be here, and we look forward to listen to extraordinary speakers today. So it is my honor to invite Dr. Tuong to give his speech as the first speaker. While he is taking the stage, I'd like to introduce him. He's going to give us the talk on how to set up an efficient IVM program. It's quite a challenging task, and we look forward to, of course, listening to it. But just a brief information about Dr. Tuong. He has been working in the field of assisted reproductive technology since 1997, when he joined the first IVF team in Vietnam. Dr. Ho is the founder of IVF-MD Group. He's a senior consultant of IVF-MD and My Duck Hospital in Ho Chi Minh City in Vietnam. Dr. Ho is a director of Hope Research Center at My Duck Hospital, and he and his group have been active in the field with more than 70 publications in highly impacting journals. And his main interests recently are frozen embryo transfer, in vitro maturation of oocytes, and quality management in IVF. He's been also active in societies, where he's been the past vice president of the Aspire organization, and he serves as the Secretary General for Ho Chi Minh City Society for Reproductive Medicine. Doctor, the stage is yours. Thank you very much.
Thank you for the kind introduction. Good morning, ladies and gentlemen. It's my great honor to be invited to talk in this prestigious Congress of ESHRE. My topic today is how to set up an efficient IVM program. This is my disclosure for the talk. And it is where I'm working, My Duck Hospital in Ho Chi Minh City, Vietnam. Actually, we have a long history practicing IVM since 2006. We had a lot of treatment cycles so far. We started with the thing called ESHRE IVM when we induce maturation by give ESHRE before we pick up the eggs from small follicles. After 10 years practicing ESHRE IVM, we decided to move away from ESHRE to improve our system. Then in 1916, we started tried a new protocol called KABA IVM. It's a biphasic IVM protocol, and we have the first baby born in 2017. So we have had 10 years experience with the new protocol, with more than 4,000 cycles, and almost 1,000 babies have been born. In ART, actually, in order to have some mature oocytes to do IVF in ICSI, we have two options. The first option is hyperstimulation, when we collect the mature egg from big follicles, and then we do IVF in ICSI. The second option is we can collect the eggs from small follicles. We mature it in vitro to get mature eggs and do IVF or ICSI. 45 years ago, we chose stimulation as a main method to collect the eggs. And this is what we have created so far. When we use hyperstimulation to obtain mature egg, we create a lot of problems to our patients. Cost of medication, cost of monitoring. We expose our follicles to high unphysiological level of FSH, and we don't know what is the effect. The patient have to bear a very big emotional burden. We also create few complications, not only your SSS. We affect the endometrium. That's why we have to do freeze and transfer and subsequent cycle. And we also have to bear the potential of long-term effects on the women and the children as well, just to obtain few mature oocytes for IVF or ESHRE. So IVM, I think, is not only to reduce the cost of medication or to avoid OSSS. It is to obtain mature oocytes in a different way, safer, less costly, and more friendly to our patient. These are the 3 common protocols published in the medical literature: standard IVM, biphasic IVM, and HCG IVM or truncated IVF. This is the new protocol, which have 2 phases of cultures instead of 1 in the old IVM protocol. This is the principle of the new protocol. We can give few days of epistasis before pickup, no HCG. When we collect the eggs from small follicle, we use meiosis inhibitors to maintain the meiotic arrest. And at the same time, we maintain the communication between the egg cells and the surrounding cells. So we save some time for the egg cells to develop before we put them into the second phase of culture, standard IVM, and then will mature genetically. So after the oocyte go through the 2 steps of culture, we'll have higher maturation rate, better egg quality, and it results in better embryo development and higher pregnancy rate. And these are our protocols that we have used in the past 10 years. This is the first protocol 10 years ago we started. We gave 2 days of FSS for priming, no HCG trigger, biphasic culture to get mature oocyte. At that time, we could only afford to grow to day 3 embryos. We freeze and transfer in subsequent cycle, an average 2 embryos for each transfer. And after establishing the protocol, we conducted a large trial of more than 400 patients. We compared the efficacy of the new IVM protocol with stimulated cycle for PCOS or PCOM patients. And we found that the pregnancy rate per transfer is almost there. We have less embryos in the IVM group. We keep improving our system later on, and after a few years, we can grow blastocysts in most of our IVM patients, and then we can do single blastocyst transfer. In 2021, we tried to do IVM without epicyst priming. For the BMOS patient, PCOS is the old name. When the PMOS patient come, we scan and we just count the number of follicles. If they have good number of follicles and the leading follicle is less than 10, we can do pickup at any day. Then we mature the egg, produce embryos, grow to blastocysts, freeze and transfer in subsequent cycle. In 2025, early 2025, we published an RCT paper, compare IVM blastocyst transfer with or without epicyst priming. And we found that we do not need epicyst priming for biphasic IVM. This is our recent protocol. In the past, we collect the eggs from small follicles, IVM, and then we produce embryo, freeze, and we transfer in subsequent cycle. In this new protocol, we started by giving estradiol to prepare the endometrium first for 8 days. After that, we do the second scan. If we find good number of follicles and the endometrium is good enough, we pick up the eggs, do Kaba IVM, give progesterone to prepare the endometrium. We grow embryo, and then we transfer fresh embryo in the same cycle. And then we can vitrify the extra embryo we got. We published recently an article compare the 2 IVM protocol. One is freeze and frozen transfer only, and the other one is fresh transfer first. And we found similar result with the first preliminary result. So that means we can transfer fresh embryo in our IVM, new IVM protocol. So what we have in 2006 for our PMOS patient, we can provide ART treatment without gonadotropin. No brain stimulation, no gonadotropin, no injection, simple monitoring, less complication. We collect the oocyte from small follicles. We do biphasic IVM to produce embryos, and we can arrange to have either fresh transfer first or freeze-dried and frozen only transfer. The pregnancy outcome, but single blastocyst transfer is almost comparable to blastocyst from stimulated cycle, although we have lower number of embryos. And the pregnancy outcome miscarriage rate is almost comparable to stimulated cycle. And in average, we have about 3 to 4 blastocysts per treated cycle for our young BMOS patient. And I think that is good enough for them to have 1 or 2 pregnancies. And recently, we tried to use the same protocol for normal ovulatory IVF patient as well. And I would like to show how we collect the eggs from the small follicle. We use 2 systems, double needle system and the single system to collect the eggs. This is how we do with the double needle system. You see the size of the follicle is very small. Usually we collect the egg from the follicle less than 6 mm. The system actually have 2 needles. The bigger one will go first to fix the ovary because the ovary is small and very movable. Then the smaller needle will go inside to approach the small follicles. And this is how we collect the egg. We puncture, and then we rotate the needles and aspirate at the same time, one by one. The recovery rate is about 70–80%, but of course we have a lot of follicles in PMOS patient. And each of the tubes have 1 ml of OPU medium without heparin. You will see the follicle fluid come out droplet by droplet into the tube. We use the same pressure for normal ovum pickup. This is how we do it in a single needle system. We have only 1 needle, 19 gauge. Usually if you want to do single needle, you have to have an assistant to hold the ovary from the abdomen because it's very movable. Same thing, we puncture, rotate, and aspirate at the same time to collect the eggs. Yeah, same pressure to normal ovum pickup. And you see again, droplet of follicle fluid, very bloody, come out into the tube. This is our laboratory protocol. Our IVF laboratory is located next to the OPU procedure room. Patients were under general anesthesia. The tube contained follicle fluid aspirated from small follicle, transferred to the laboratory immediately after pickup. We identified a small and compacted COC. All of them are GB from bloody fluid, wash and transfer to the pre-IVM culture. We culture it for 24 hours, and the next morning we wash and transfer to the second phase of culture, the IVM culture, and then we culture it for 30 hours. In the next afternoon, we will check maturation, we do ESHRE, and we follow the same as the normal IVF patient. So this is the clip to show how we identify the small COC from the fluid aspirated from small follicle. The laboratory is located next to the operation room and through the small hatch. We pour the fluid into the petri dish to find the small COC. The COCs are very small and compacted compared with the one expanded in stimulated cycle. And when we identify it, we wash it in the washing medium. After the first search, we filter all of the fluid through the cell screener to find any COC left. Usually the very small one is difficult to find. Most of the case, we can find COC left in the fluid after the filter. Now recovery rate again is about 70 to 80%. So in PMOS patient, we usually have a high number of oocyte collected. This is the 3 types of COC we can identify in the fluid. The best one is the one with have more surrounding cells, and the worst one is the one with only few layers of cells. Again, I repeat again our procedure, lab procedure. First search, we put the fluid into a petri dish and fry the tiny COC, and then the second search is after we filter to the cell screener. The first wash is in the safety cabinet class 2, and then we move to the IVF chamber to do the second wash before we put the COC into the pre-IVM culture. And this is our culture system. During the egg pickup, we use standard IVM medium. We add CND and estradiol. For the first step of culture, we use standard IVM culture medium with CND, insulin, epicis, and estradiol. In 7% CO2 and 20% oxygen. The second step of culture, 30 hours, we put in IBM standard culture medium. We use amphiregulin, insulin, epicis, and estradiol. And again, 7% CO2 and 20% oxygen. The first photo is the COC after pickup. And the second photo is the COC after first pre-IVM culture. You see the cumulus still compacted. That means the communication between the egg and the surrounding cells is there. And after the second phase of culture, you see the cells expanded. It's very similar to what we see in the stimulated cycle. And we do IVM and IVF in the same setting. So we try how to allocate time that it can go well with normal IVF cycles. And this is what we do. We do pick up at 9, 10 a.m. and we culture the IVM phase. Next morning, we move them down to second phase. And then the next afternoon, we check maturation and do ESHRE. After that, fertilizer check-up embryo culture is exactly the same with the normal IVF cycle. So it's all very well with our IVF program. And this is we published a video showing how we do IVM infertility and sterility report recently. You can scan QR code to browse the full video. And regarding the safety of basic IVM, we have done more than 1,000 cycles. No SSS, no installation, no other communication. We already have 1,000 baby one. We published 4 papers to follow our children born from IVM. And this is the first two. This is the children from our large RCT published in 2020. We follow them up to 2 years and 5 years. And we found no difference on the development of children after IVF and IVM. We also have another 2 papers. The third one is we compare the development of children up to age, IVM children and children from natural conception. The last paper is one we analyze the epigenetic from the tissue, the infant tissues from children by IVM and IVF children. We found not much difference between the two. So who are the candidates for our IVM program nowadays? Of course, the best group of patients is those who have high risk of SSS, including PMOS, BCOM, and high risk of SSS. Patients who do not respond to gonadotropin at all, or patients who have suboptimal response. They would have better without stimulation. Patients who have contraindication for ovarian stimulation, fertility preservation, either cancer or for social reason, patient with severe diminished ovarian reserve. Some of our patients, they do better without stimulation. We have difficult case, repeated failure with many IVF cycle. They can still have the same change without stimulation and not a treated cycle. And now we have patients who come to do IVF and they don't want injection, so they can have a more friendly treatment with IVM. My take-home message is the setting up for biphasic IVM non-gonadotropic ART treatment is feasible and effective. You don't have to buy expensive equipment to do it. Biphasic IVM could be a promising alternative to some groups of patients in ART practice. And I think the story of biphasic IVM has just begun. We're not there yet. And I think that we still have a lot of rooms to prepare the system in the future with better results. So I'm looking forward to further improvement in the future. Maybe you don't have to change now, but you have to prepare for something happen in the next 5-10 years. Thank you for your attention.
Thank you very much, Dr. Ho. The floor is open for discussion, if there's any questions. Dr. Sidler?
Admirer of what you're doing. Could you explain why you don't need HCG or LH in the IVM culture media?
We apply IVM based on the basic study from the group of Brussels. Johan Smith, of the leader of the group here, they're not using HCG, and we don't see any role of HCG in this, but we have never tried it.
Fantastic, thank you.
Hi, thank you. Mohamed Khrouf from Tunisia. I'm here. My question is, you said that the patient can choose the day of the oocyte pickup. Is it possible to do it in any time of the cycle, meaning when there is a dominant follicle? Are we supposed to find atretic oocyte or not? And the second question, if I may, what are the blastulation rate and the outcomes in terms of efficiency in the lab? Thank you.
Yeah, for the pickup time, the important thing is the number of follicles. And when the leading follicles is less than 10, and recently we found that if less than 8 is better, then we can do pickup at any time. For BMOS and irregular cycle, actually they don't have cycle. We can collect egg at any time if we found good scan, good image in the scan. For ovulatory women, usually we do the pickup on the first 5 days of the cycle. Of course, the leading follicle has to be less than 10. Then we can choose the day of pickup if there are no leading follicles. For the effectiveness of the culturing system, we found that the quality of the eggs and embryo is still below the stimulated cycle. We are not there yet, but we have been improving. The blastulation rate is about 40-50% based on the 3 embryos, and the implantation rate of blastocyst, single blastocyst transfer is almost comparable to what from stimulated cycle.
Thank you for your presentation. My name is Chizara from Nigeria. It's just an exciting information you gave us this morning. I want to ask about diminished ovarian reserve for patients that have severe diminished. What's your percentage of success with in vitro maturation, knowing that genetic problematics is their major problem?
This is a very interesting experience. We have own patient with low ovarian reserve, and they spend a few cycles of stimulation. They have a few eggs, no embryos, or even no eggs. We wait the cycle when we have they have more number of AFC. That means we can approach more follicles for those kind of patients, because when you do stimulation, some of them will disappear. And we still can arrange to mature the eggs, produce embryos. I think the pregnancy rate, I think, is comparable to stimulated cycle. But the thing is, they can still can continue treatment with, we can have a similar or better result without stimulation.
Thank you.
A very quick question. I noticed you use the CO2 level 7% and the oxygen level is 20%. So what's the reason for the change? And the clinical question is, if someone you put on the birth control pill for a prolonged period of time, as long as the follicle less than, as you said, 6 to 10 millimeters, you can do retrieval anytime also, correct?
Yes. Okay. We can do, if the follicle, leading follicle is not big, we can do anytime. The problem is some of the follicle is already on the atretic way. So when we collect, the quality of egg is low, but we don't know how to identify the patient. Regarding to the culture system, we choose 7% CO2 because that is that will have the pH level that we want. Because we measure pH level in our droplet, and we find that 7% CO2 is what we want. We did study to compare IVM culture with 20% O2 oxygen and 5% oxygen. We found that 20% oxygen will do better in IVM culture. For embryo culture, 5% is better, but for IVM culture, we think that 20% oxygen is better for IVM.
Okay, so the question comes right away. So what's the ideal pH by using 7% CO2?
7.3 to 7.4 is what we aim for.
Thank
I think we still have room to improve the culture system.
Thank you.
We have time for one more question from the back, please. The gentleman was there first.
Yes, I'm Monsef Ben Khalifa from France. For the normal responder patient, are you giving some androgen to the patient earlier to make it as PMSO-like to get better response? This is my first question. And my second question, do you have any higher miscarriage after embryo transfer from Kappa IVM? Thank you.
We do not give androgen before the pickup. We just wait until they have a higher number of AFC to go and pick up. With the new, the fresh transfer protocol, on the preliminary result, we find a little bit higher miscarriage rate, but only on small number of samples. But in the previous study, we found that the miscarriage rate is not different from the stimulated pregnancy.
That's the freeze-all is better than fresh transfer. Thank you.
Yes, thank you very much. We have a lot of questions online also, but maybe addressed later. So it's my pleasure now to introduce the next speaker, who is Michel De Vos. So Michel De Vos is Associated Professor in Reproductive Medicine and Senior Medical Director at the Brussels IVF Centers, the fertility clinic of UZ Brussels, VUB. And he studied in Belgium, but actually holds a PhD here in UK at the University of Leeds. And his current research activity are focused on reproductive endocrinology, but also, of course, on fertility preservation, and he's a leader in the field of IVM. I think you all well know his work on it.
Thank you, Isabelle, for this kind introduction. And I'm from Belgium, Europe. So after this presentation with beautiful data from Vietnam, Asia, I would like to represent the European point of view. We have many similarities, but we also have some differences. Our patients are not from Vietnam. They have a different PMOS phenotype. Women in Europe with PMOS have a slightly higher BMI. They are more often hyperandrogenic. And there's also a difference with regard to the culture system. Although biphasic IVM was engineered in Brussels, it is not available in the clinic in Europe because of regulatory hurdles. So we have to rely on a monophasic system that we have been using since 2007. I have no conflict of interest to declare. I do not invite you to offer IVM for all patients. Neither do I invite you to try IVM wherever. I think it is important to understand that there is a learning curve and that you need to get some proficiency in egg retrieval technique, but also in the laboratory, efficiency is really important. So this is why the international PCOS group have advocated that IVM should be offered in units with sufficient expertise. And this is also the point of view of ESHRE, and they have banned the label of experimental, so it's no longer an experimental procedure since 2021. And also ESHRE have advocated in their good practice recommendation guideline that IVM is not experimental if it is offered to women with PMOS and hyper-responders. So we have to make some compromises with our monophasic system because probably the biphasic system is slightly more efficient in terms of maturation rates. So we only offer IVM to women with severe PMOS, patients with a severely increased level of anti-Mullerian hormone. And most of these patients do not start IVM as an initial treatment. Many of these patients have already undergone conventional ovarian stimulation in other clinics, and they were disappointed with the experience. They had severe side effects from hormones. They developed ovarian hyperstimulation syndrome sometimes. But also in our clinic, we see many patients with PMOS who start ovulation induction treatment with oral agents, letrozole, and then after 4 unsuccessful cycles of ovulation induction, we offer them, if this wants to proceed, sorry, this is blocked. Can you advance the slide, please? Yes. After 4 unsuccessful cycles of ovulation induction, we offer them 2 options. Either they go for conventional ovarian stimulation and IVF or ICSI if they put efficiency and success rates as the highest priority, and if they don't really care about the eventual side effects of hormonal stimulation. If, on the other hand, the patient would like to have a more patient-friendly treatment, then she would be offered IVM. So patients can choose between high efficiency, high burden, or slightly lower efficiency and lower burden. Does this mean that we have to offer IVM for everyone? No, of course not. So if you have a patient with only moderately elevated AMH levels, normal BMI, then you can expect that the ovarian response to ovarian stimulation will be quite predictable. And to these patients, we should not really offer IVM because IVF, conventional stimulation, can give you very good results. If, on the other hand, and this is depicted in the lower ultrasound scan images in the left lower corner, you see women with ovarian volume, which is really increased with a lot of ovarian stroma, very small antral follicles, very high number of antral follicles, high AMH, and in these patients, ovarian response to ovarian stimulation is more difficult to predict. Either you stimulate with a dose that is too low, and then you will have monofollicular or oligofollicular response, or the dose is too high, and then you will have very strong hyper response. So in these patients, IVM really can give you lots of comfort and also good success rates. And the success rates of IVM in women with very high AMH levels is depicted in this figure, and this is a figure from a retrospective study that we published in Human Reproduction in 2024, where you can see in the higher AMH strata that the blue line depicts success rate, which is ongoing pregnancy rate per cycle after conventional ovarian stimulation and IVF, and the green line depicts ongoing pregnancy rate after IVM. And you see that these lines converge, which means that in women with an AMH above 10, we see that the success rate is becoming non-inferior for IVM, which is actually the best suitable population for monophasic IVM in our clinic. And here I would like to just show our video of an egg retrieval, which is very similar to what my Vietnamese colleague has shown. Our follicles are slightly larger, as you can see here, because we do give gonadotropins to our patients. We typically give 2 or 3 days of gonadotropins to increase the follicle size to between 6 and 10 millimeter, which makes egg retrieval less difficult for the operator. This is a table that I adopted from David Albertini, who presented this figure, I think, more than 10 years ago, where he compared in vivo maturation with in vitro maturation. And I think we all have to agree that in vitro maturation is much more complicated for the cumulus oocyte complex to result in a competent oocyte, because there are many molecular pathways that are still incomplete and inefficient in small antral follicles. And this means that blastulation rates are typically lower after IVM. And we have to make compromises, which means that if the number of embryos that we obtain after IVM is on the lower side, then we do not necessarily want to go to blastocyst culture. So we actually look at embryo development on day 3 after ICSI, and then we decide whether or not to go to the blastocyst stage. And this is just an illustration here, 2 very similar patients with PMOS, high AMH levels above 10, normal BMI, very similar looking ovaries. We typically give them 3 days of HPHMG before egg retrieval, no HCG trigger, of course. We have very high numbers of COCs, 41 eggs in the first patient, 70 eggs in the second patient. The first patient had 14 blastocysts after monophasic IVM, and the second patient apparently struggled to have good quality blastocysts. So it's quite unpredictable still, and this is probably related to, 1, to the culture system, and second, to the small follicles. Many of these follicles are unsuitable, and this is probably where we have to find the sweet spot in follicle size. I think that we can say, and this is a picture by Rob Gilchrist from Australia, where he shows that if you have very small antral follicles below 6 millimeter, then probably biphasic IVM has a major benefit compared to monophasic IVM. And in these small follicles, you probably do not need gonadotropin stimulation. Whereas if we use a more simple IVM system, the monophasic system, then we probably can benefit from some kind of FSH priming to have slightly larger follicles and a better follicle selection. So we were thinking whether the type of gonadotropin would play a role in priming the follicles for IVM. And we conducted an RCT. We published the results last year in Human Reproduction, where we compared cholefolitropin alpha, which is a long-acting FSH, to 3 days of recombinant FSH, and see whether with cholefolitropin alpha we would obtain higher numbers of oocytes and higher numbers of live births, which apparently did not turn out to be the case. We had a slight advantage even for daily injections of recombinant FSH compared to corifoliatropin alpha. So on average, we had between 23 and 31 COCs per cycle. And this was corresponding to a number of embryos on average between 3 and 4. I have to admit that not all patients had blastocysts, and the live birth rates per cycle were also very similar. So this means that in a patient with high AMH, you can obtain a live birth rate per cycle from 40 to 45%. And this is yet another case, because the title of this talk is Difficult Patients, and I would say that this is a patient with an AMH of 43.8 nanograms per ml, so extremely high antral follicle count. So in this patient, I'm sure that you will struggle to obtain a predictable ovarian response after conventional ovarian stimulation. So in this patient, we gave 3 days of gonadotropins before egg retrieval, and we obtained no less than 146 COCs, 29 blastocysts cryopreserved. So obviously this is a very unusual result, but this is obviously just an example of a difficult patient where IVM can definitely give you a live birth. And interestingly, a few days after egg retrieval, we did an ultrasound scan of the ovaries in this patient, and we found that actually the ovaries are very plastic organs. They are dynamic and they revert to their normal appearance only a few days after egg retrieval. And this is also a major advantage of IVM, is the low complication rate. So there is no bleeding, no risk of OHSS, and patient comfort is much better compared to conventional ovarian stimulation. But then another group of patients are women with FSH resistance. So women who do not respond to ovarian stimulation, probably because they have antibodies against the FSH receptor, or they may have mutations in the FSH receptor gene. So gonadotropin-resistant ovary syndrome is a very unique and rare condition where IVM is the only option for these patients to have own genetic offspring. This is an example of a 30-year-old woman with a good AFC of 40 antral follicles. She had irregular cycles at a young age, but then she had amenorrhea after discontinuing the combined oral contraceptive pill. And we found that she had endogenous FSH levels of 65, LH levels 43, although she had a normal antral follicle count, actually a very good antral follicle count. So this is not a woman with ovarian insufficiency, it is a woman with ovarian resistance. So if we look at her ovaries, you see a quite good number of antral follicles, and we performed an egg retrieval, and we had 30 oocytes and 8 mature oocytes after monophasic medical IVM. She had a few embryos, and she eventually also had a pregnancy after frozen embryo transfer. So this is what IVM can do for your difficult patients with FSH resistance. We also did a small study comparing monophasic to biphasic IVM, because there was a time when biphasic IVM was available in a research protocol in our clinic. And there we compared both approaches, and we looked at ongoing pregnancy rate per patient, depending on whether the patient had undergone monophasic or biphasic IVM. And the number of oocytes per cycle was similar. Maturation rates were also quite similar. As you can see here, in women with FSH resistance, maturation rates are only between 30 and 40%, but 1 in 3 patients actually had a baby after IVM, although patients had FSH resistance. So IVM is a promising fertility treatment in women with gonadotropin-resistant ovary syndrome. Also in cancer patients, IVM can be interesting. For instance, patients who cannot undergo ovarian stimulation because they have to start chemotherapy at a very short time frame. And we can also offer IVM in combination with ovarian tissue cryopreservation. You can extract cumulus oocyte complexes from antral follicles that are embedded in the ovary, and you can do that outside the body of the patient. So IVM has a role in cancer patients. This is an example of a patient with leukemia. She's 28 years old, and she's very sick because she has a diagnosis of acute lymphoblastic leukemia. She has to start chemotherapy in 2 or 3 days from day of referral. She has an antral follicle count of 21, AMH 2.3 nanograms per ml, and actually the hematologist and the patient agree to undergo an egg retrieval for IVM. So we collected 14 COCs, and after IVM this patient had 10 mature oocytes, and this is when she can actually start chemotherapy. And interestingly, in these patients, as soon as they have molecular remission after induction chemotherapy, they can undergo ovarian tissue cryopreservation, because then the risk of residual disease in the ovary is extremely small. So you can have both approaches in this type of patient. So you start with an IVM egg retrieval, then you give her chemotherapy to induce remission, and then you can remove an ovary before she undergoes stem cell transplantation. And this is how we actually approach patients with leukemia these days. Some patients are diagnosed with cancer when they are pregnant. This is a patient who actually underwent, well, she had a miscarriage. HCG levels were still very high, more than 1,000 units per liter, when she was diagnosed with invasive breast cancer. So how are you going to stimulate the ovaries in a patient with high levels of HCG? It is feasible, and I agree that a recent case report was published in a patient who was pregnant and who underwent ovarian stimulation. So it's actually possible to do ovarian stimulation in a pregnant patient, but it's more complicated. So in this patient, we did not perform ovarian stimulation. So we gave her one shot of 150 units of HbHMG before egg retrieval, and we collected a quite good number of oocytes and a good maturation rate. So this patient had mature oocytes cryopreserved before embarking on chemotherapy, in spite of being still pregnant. She had a recent miscarriage. So in this, I would say, I would also consider as a difficult patient to manage in fertility preservation. Is fertility preservation using IVM a risky approach? Apparently not. Our colleague from Paris, Michael Grünberg, has extensive experience with IVM in cancer patients, and the risk of bleeding is extremely low. He reported a risk of less than 1% of bleeding. Rescue IVM, for the final couple of minutes of this talk, rescue IVM is yet a completely different approach compared to standard IVM, because in rescue IVM, you try to mature oocytes that are denuded oocytes after conventional ovarian stimulation. These oocytes do not have the necessary support from cumulus cells to obtain maturation, so they are intrinsically less competent, and the success rates of rescue IVM are quite low. So for patients with very poor prognosis, rescue IVM can be an option with limitations, but as soon as you can obtain a euploid blastocyst after rescue IVM, then apparently the potential is similar compared to in vivo matured oocytes. And this is data from our colleagues from Denver, Colorado. So in conclusion, I would say that IVM, even though we have to rely on relatively simple culture systems, we have to make some compromises. IVM is a low intervention, mild approach to patients with excessive antral follicle count. So the better your culture system, the less elevated your AMH might be to accept a patient for IVM, I would say. It is a safe procedure. Clinical outcomes are slightly lower compared to conventional ovarian stimulation, but several patients would accept a lower chance of success if they get a lot of comfort in return. Thank you for your attention.
Thank you very much for this excellent talk. It's open for discussion. Yes, there on the right side.
Yes, please.
Here.
Yeah.
On the
Excuse
right
me.
side.
Yeah.
There.
Raja from Jordan. My question is, what is the dose of gonadotropin you give the first 3 days before the IVM oocyte pickup?
Well, it's not rocket science, it's just empirical use of what we have. We have HPHMG, and HPHMG is available in units of 600 units in one cartridge in Europe. So you can just distribute the dose for 3 days. So we give 225, 225, 150. So that's 600 units altogether.
Yeah, and the other question, if we start ovulation induction for a lady, let's say for 7 days with no response, can I continue immediately for IVM the same cycle?
Yeah, very good question. So we've had patients who did several weeks of gonadotropin injections with no dominant follicle appearing. So we had to say, okay, let's abort the ovarian treatment with ovulation induction and let's convert to an IVM egg retrieval, and that's perfectly possible.
Thank you, Michel, for your amazing lecture, as well as your devotion to the IVM program. So I'm Dr. Vũ from IVFMD Vietnam. My curiosity about your current maturation rate with your monophases IVM culture right now, and your strategy for the cases with the severe BCOM with a very high number of the antral follicles. What is your strategy to decrease the embryo weight test? Thank you. Embryo weight test. Still a lot of embryo lapse when the patient have enough babies. Just like the cases you show.
The overconsumption.
Thank you.
Yes, I agree. So the average maturation rate in a monophasic system is 45% in our lab. To be honest, I have no good suggestion for your second question. Obviously, as we did not know beforehand that we would have so many blastocysts after IVM, I just punctured all visible follicles. Obviously, it took me a while to get 146 oocytes, but in this patient, there was a risk that we would only have 1 or 2 blastocysts. So I couldn't say, let's stop after 1 ovary, because then if you don't have enough blastocysts, then you have to repeat the procedure. But I agree, this is of course overconsumption, but this is just a almost ridiculous example of what IVM can do for your patients.
Thank you.
Yes, Dr. Silva.
Work. I wanted to ask, Dr. Vuong, I believe, usually is not priming with FSH, and he doesn't use HCG in the culture media. Now, you are priming for 3 days, just so you can more easily retrieve the eggs from the follicles. Do you also not use HCG in the culture media, or do you use HCG in the culture media?
Okay. So we do have FSH and HCG in the culture media, yes, to promote maturation.
And do you want to comment on why you feel it's necessary? Well, we've always used HCG in the culture media in varying concentrations, and how they can do this without HCG in the culture media.
How they can use, sorry?
How is it they get away with not using HCG in the culture media, and we do use HCG in the culture media?
Yes, but they use amphiregulin in the culture system.
And that's why.
So if you use amphiregulin, then you bypass the HCG system.
I understand now. Thank you very much.
Maybe a question from the back, because...
Thank you. Lisa Webber from Imperial and Singapore General Hospital. Brilliant talk. Loved the fact that you were so pragmatic about it. I was a bit alarmed when you only talked about doing ovulation induction with letrozole, but you did mention that you do put some of your challenging cases through gonadotropin ovulation induction. I think we forget about that, because actually in some of the challenging patients for IVF, GOI can work very nicely. But I wondered if you have any idea about your cumulative pregnancy rates from IVM. It might be a bit soon for you to know that, though.
No, but if you consider the definition of cumulative live birth rate as the one baby after using all embryos derived from one cycle, then cumulative live birth rates, as we showed in our paper, are only slightly lower compared to conventional IVF per cycle. Obviously, if you want to create one family with one cycle, and you want to have several children, but that's not the definition of cumulative live birth rate, but then obviously with conventional stimulation, you have a higher chance to achieve a family size compared to IVM.
Thank you.
First, I would like to thank you for your very stimulating lecture. And I wanted to ask a couple of questions regarding rescue IVM. As we all know, it's still a debate. And I wonder, when do you perform rescue IVM, whether you replace embryos without performing PGTA, and whether you make any fertility preservation, I mean, social preservation for those who don't have enough oocytes.
Yeah, so it's a very important question, but it's slightly outside the focus of my talk. So I have to say that we do not perform rescue IVM very often. And that's simply because the culture media that we use for rescue IVM are probably not efficient enough. So I agree that some colleagues from Spain have looked at different culture systems that you could use for rescue IVM, and some culture systems are more efficient than others, but the culture system that we use for rescue IVM is far from optimal. So we only offer rescue IVM to patients who have a very large proportion of metaphase 1 oocytes after conventional stimulation. If you do rescue IVM in patients who have only GV oocytes, then the success rates are really low. So you really want to focus on those patients who have some kind of maturation up to the metaphase 1 stage.
Thank you. Question from the front, short question, please.
Thanks, Michel, for the beautiful talk. Lucia from London. I have a question regarding the aneuploidy rate of your embryos created with the IVM. Rather, you have this data compared to the embryos created with the IVF.
Okay, well, to be honest, we don't have much evidence on the aneuploidy rate because we did do some aneuploidy screening a long time ago, and we published that, I think it was 10 years ago, but then at that time we were still performing chromosome testing on blastomeres from cleavage stage embryos. We have not done a study on trophectoderm biopsies after IVM, so I don't really have the answer. The only thing we see is that miscarriage rates, early pregnancy loss rates, are very similar compared to conventional IVF.
There is a question online that it's recurrent about haploidy rate in advanced maternal age, if you think that it could change something using IVM procedure. I jump on that.
Well, to be honest, I do not believe in the indication of IVM for advanced maternal age because the IVM system cannot correct the intrinsic defects of an aged oocyte, to be honest.
To start our own Kappa IVM trial. 2 questions, please. Can you comment on your thoughts on alternative IVM systems such as Fertilo or Gameto using the interstitial-derived stem cells? That's one question. And the second one, very interestingly, you're freezing M2s from IVM for oncofertility. What are your outcomes on the thaw of those, or we haven't had that longitudinal data yet?
Yeah, okay. So, we do not use Fertilo, so the human-induced pluripotent stem cells, but I'm a strong believer that there is lots of potential in that system, but we still have to wait for the results of the phase 3 trial that is currently ongoing in the United States. And we expect the results, I would say, by the end of the year. We expect some results, and I'm really curious to know what they found. With regard to your question in patients with cancer, the number of patients who have returned to use their IVM oocytes is too low to give you reliable data and answers, but we have seen a few pregnancies already, a few babies in cancer patients. Thank you.
Yeah, go ahead.
Thank you. Thank you very much, Dr. Vos. I'd like to thank both the amazing speakers, and I declare the session closed now.